Thank you, Chairpersons. I'd like to thank all the organizers, particularly Dr. Krishna Sheshadri. I always admire him because every meeting he comes up with something unique and gives challenges to speakers. So when he asked me to talk on how our advances in the past 3 decades change our approach, initially I thought, what am I going to talk? But then as he said, as I started preparing this, a lot of memories came back of the 30 years, and therefore, thank you, Krishna, for inviting me to give this talk. I do have a lot of people with whom I work. I don't think it's really related to this talk, because it's more of a historical kind of a talk. So getting back to this question, how have the advances in the past 3 decades changed our approach to treating diabetes? My thoughts went back. I said, let me rewind to the year 1981. And I chose this year because that's the year I finished my MD. So I finished my MD and then joined my father. That's Professor Vishwanathan, my father, and started working with him. So I started looking at what did we have those days and what has changed in the last 35 years. And for many of the younger people in the audience, many of this, what I'm going to present today, may be totally new. So at that time, let us say, I'm just assuming, I'm just making this up, let's say a newly diagnosed patient, 24 years old, came to us. His name is Mr. G, and he presented with recent onset diabetes. Those are his blood sugars, again, completely made up, just imagining a case like that. So fasting plasma glucose 286 and postprandial plasma glucose 376. Now these are the two investigations definitely we would have done at that time. So how would I have proceeded in the year 1981, just after my MD, working with my father? Now at that time, remember, we did not have HbA1c to start with. So for those of you who look shocked, there was no A1c at that time. We did have a test called A1. That's a total HbA1. But guess what? It was a calorimetric test, which meant that there were 17 steps in doing that test. Quite often come out erroneous. Imagine a biochemical test having 17 steps. You can imagine how it will come out at the end of the day. And of course, it took several hours to get the result, at least 10 hours, which means we took the test in the morning. We'd be lucky if we got it back the same day. Late at night, the biochemist would still be working, and somewhere after 6 or 7 o'clock, they will give this result. Those days, we did not have internet, we didn't have emails, we didn't have everything. So how would I send this to the patient? I would send it by post. It'll probably reach him after 3-4 days. And then he'll call me back and ask me, now what do I do with this test? And I'll say, well, I've already given you the prescription now. Now what do you do with this test now? And therefore you can see the fallacy of getting a test, an A1C test, long after the patient has gone home. And if he's from some other town, it may take him a week to get the result and so on. So that's how we lived those days. So how would I have treated this patient? Okay, with this blood sugars, with this A1C, which came the day later, I now start to treat the patient. Well, it was simple. Life was simple those days, and I'm sure Professor Munichodappa and Prasanna Kumar and the seniors in the audience will agree. We had only 2 drugs then. We had glibentamide, which had just come actually. 69, 70, 71 was when it actually came. So it cost about 10 paisa. So the treatment was incredibly inexpensive those days. We had penformin, which was our favorite drug. Metformin was available, but nobody really knew about it and nobody was using it. Penformin was what we used. And often we use these drugs in combination. So if you added those together, about 14 paisa, 20 paisa a day was the treatment of diabetes in those days. As I said, metformin became available around that time, but was less used. Glipizide was just becoming popular. Glycoside was not available at that time. And most of the other drugs that you heard about from Dr. A.K. Singh were definitely not available at that time. How would home monitoring have been done? So I would have sent the patient home and said, we need to monitor your sugars. Glucometers were just coming in, but they were messy, they were cumbersome, they were unreliable, and they were certainly too expensive. In fact, the glucometers those days that we had to wash the strip. So you put the strip there, you pour water on it, then you dry it, you wait for a few minutes, then you put it into the machine, and the results were often atrocious, what you got, okay? So what did we do? My father and I would have said, do the Benedict's test. This is the gold standard. So I'm sure all our fellows in the audience will remember the Benedict's test, where the fellows were asked to do the Benedict's test themselves. So we'd have taken this blue solution and then heated it, and then we'd have said, okay, there's 1 plus 2 plus 3 plus urine. If they could afford it, they would have used a diastics, okay, a simple dip and read. Not very popular because it was too expensive. Only Benedict's test was affordable by the patient. And I had some patients who till recently continued to do the Benedict's test, because that's how the last 40, 50 years they continue and they still believe in it. I had a type 1 patient who continued to do Benedict's test until quite recently. How would the patient have responded to this particular treatment? Okay? Almost definitely at some point the glibenclamide would have produced hypoglycemia. We know that. And there's a small risk of lactic acidosis with penformin. Luckily, not too many cases of lactic acidosis, even with penformin, I'd report from India. If I remember correctly, I think 3 or 4 in the entire country. Okay? One from Chennai and I think one from Bombay. Dr. Chandalia had reported, and probably one more. But even then, that small risk was there, and of course, US banned it, and a few years later, India also banned it. Now, screening for complications. We were just getting set, our center was just getting set, so routine screening definitely was not done. Retinopathy, nephropathy, and so on. So what would we have done? We would probably not have known at the time, certainly not at the first visit, whether the patient had retinopathy or nephropathy. Microalbuminuria certainly was not available. We might have had a urine test for dipstick or one of the tests for the heat test for albumin. If you're lucky, we would have done that. Creatinine we probably would have done, urea and creatinine, but that's how we would have screened for the complications, nothing beyond that. I would have tested the lipid profile, and let's say this is the result I got. Cholesterol was 286, LDL was 170, triglyceride was 320. Now, what drugs did we have at that time? We had clofibrate. That's the only drug we had. It had a lot of side effects, as you know. We used to use garlic pearls. Himalaya drug, I think, used to produce garlic pearls, and that's what we used to treat cholesterol, however high the cholesterol. Even if you had 400 cholesterol, that's all we had. Statins were not available, fenofibrate was not available, and most of the other drugs we use today were not available. Let's say as an alternative scenario, the same patient comes in, remember he's 24 years old, he presented with severe diabetes. We tested his urine ketones, which we used to do routinely, along with the sugar and the albumin. A urine ketone test was positive, and let's say it was 3 plus positive. The serum Rothras test we did not have at that time. So based on this, I would have had to make a diagnosis. What type of diabetes does he have? If he had presented a little late with glucotoxicity, I would have said, can this be type 1 diabetes? 24 years old, ketones positive, severe diabetes. Can this be type 1 diabetes? Okay, no harm if you think of type 1 diabetes in that situation at that time. So then what would I have done? I would have started insulin. Okay, and what insulin did we have? We had bovine insulin. Okay, we had the Boots bovine insulin. I was trying to get a picture of the Boots bovine insulin. Believe it or not, I couldn't find it. It's not even available in the net now. It's gone. Is there? You have? Please send it to me. The old pictures we have, it must be there. I'm sure in my old slides, you know, we used to have the earlier transparency slides. They're all gone. So you send it to me. It's of historical importance. So this is what I could get. Of course, porcine insulin had also come. It's freely available. Human insulin was not available. Remember, human insulin was discovered in 1981. And in UK, when the first presentation was made by the director of the company which discovered it, I was in the audience with my father in 1981. It was not yet available in the UK. So they're talking about human insulin, how it was discovered. And so when I got up and our question time came, and I got up and said, so when will it come to India? The rather arrogant reply that I got from that American director of that company was that India doesn't exist on our map. So that was the state of insulin being brought to India, human insulin being brought to India. Okay? What syringes would we have used? We would use glass syringes. Boil them and reuse them again and again. At some point, disposable syringes became available. But the needles were big, they were thick, and extremely painful. So taking insulin injections was a painful process. Let's now fast forward 3 decades and see how these advances have changed. Let's say the same Mr. G now comes to me in the year 2017. He has recent onset diabetes, the same blood sugar levels. How would I approach this patient? I would say today is the era of precision diabetes. We are trying to put a label as accurately as possible for every patient that we see. So I'll say, can this patient have type 1 diabetes? Can he have early onset type 2 diabetes? Can he have maturity onset diabetes of the young, MODY? Can he have fibrocalculous pancreatic diabetes, or can he have any other form of diabetes? First, I'd like to classify this patient. So when I investigate him, the first thing that we do at our center is to take a detailed pedigree chart. And this is something right from my father's days we're doing, and we're still doing it. So I take this pedigree chart, and I find that this proband here, shown right at the bottom, his father has diabetes. And if you look at your left side of the graph of this pedigree chart, you'll find that many members on the father's side had diabetes. His sisters and his brother and so on had diabetes. Some of the children have also got diabetes. If you go a generation earlier, his father's mother also had diabetes. So the maternal grandmother also had diabetes. If you look on the mother's side, she didn't have diabetes, nor did any of the people on the maternal side. The two who had it were in-laws who married into, thought to have type 1 diabetes, who on genetic testing have now been converted back to tablets, because this is an era of precision diabetes, and it shows you how it impacts the lives of people. Now let's take a common garden type 2 diabetes patient coming to us in the year 2018. Let's say 2 days ago, I have a patient who comes in, similar kind of blood sugars. We know he has type 2 diabetes. As other speakers, Dr. Singh and others showed you, today we have a lot of choices. We have metformin, we have a series of sulfonylureas, we have many alpha-glucosidase inhibitors, we have pioglitazone, we have many DPP-4 inhibitors, we have GLP-1 analogs, and we have SGLT2 inhibitors. Okay? And we have some guidelines how to use them. For example, we all would look at the efficacy of the drug, we look at the risk of hypoglycemia, the risk of weight gain, ease of use, tolerability, and of course, we'll also look at the presence of comorbidities, does this patient have renal failure, age, and finally, last but not the least, the affordability of the patient. Let's just take weight gain. We know that many oral hypoglycemic agents can increase your weight. Some are weight neutral, and we do know we can offer them a full platter of insulins from which we can choose. Advances in insulin delivery. Compared to the glass syringes and the disposable syringes, we have come a long way. We have the insulin pens, better and better, and we also have devices such as the iPort, where you can use insulins without any pain. Insulin pumps have come to stay from the older ones, which were huge and rather cumbersome and very expensive, to better and sleeker and better ones. We also have insulin pumps which can suspend when you have a hypoglycemia and restart again when your blood sugars go up and so on. These are all dreams 20, 30 years ago. Even when working in Germany with Professor Pfeiffer, these used to be the dreams. And some of our teachers, like Professor Pfeiffer and so on, died without seeing any of these advances come true. How happy they would be if they saw that today. There are also combinations of insulin and GLP analogs in one pen. And I refer to the IDEG Lira, where you can have a GLP-1 analog as well as an insulin in the same pen. You can also have the iGlar Lixi pen device. We also have devices such as this, the flash glucose monitoring systems, what we call as the ambulatory glucose profile, where you can get 2 weeks results of a patient to decide the next course of action. In my opinion, this has actually changed. This has been the single most important paradigm shift in my treatment of diabetes, because earlier, if I wrote a prescription for a patient, only 3 months later, I would know how he responded. Here, within 2 weeks, I know hour to hour how the patient is responding. For example, first week he may not respond, second week is getting hypos, and so on and so forth. Now let's, in the last few minutes, talk about a little peep into the future. If I was alive in 2025, and Krishna back for another debate talk and said, now go back another 30, 40 years now and tell us what happened. So in 2025, what would we have had? Okay? We might have lasers to do finger pokes. It's still a little painful to do these finger pokes. Maybe we can use lasers. We may have future insulins. We have insulin patches which can deliver the insulin as required. We have smart insulins. These smart insulins will only work if the sugar is high. They'll switch off when the sugar is under control, okay? And devices such as these are already becoming available. And I predict that 10 years from now, we will have all of these. We will have dual pumps. We'll have artificial pancreases, which will give the glucagon, the sugar goes low, and will deliver the insulin when the sugar goes high. And critically keep matching those two to maintain perfect euglycemia throughout the 24 hours, something which we are not able to do today. We may have the bionic pancreas, which is what I just talked about today. The era of precision diabetes or personalized diabetes, ladies and gentlemen, about which I'm very, very passionate and working very hard at now, I predict will come in 5 years' time. So when a patient sits in front of you, you will no longer juggle with which sulfonylurea, with which oral drug to use and so on. A computer will probably tell you that for this particular patient, with 99.9% accuracy, this drug will work. Once you put in the phenotype, maybe the genotype, maybe the metabolomics of that particular individual, or the transcriptomics of that individual, all may be available in a chip. And you put that, and the computer will tell you, this is the best drug for this particular patient. The day is not far off. What about the diabetes cure? Is it going to come? Well, I can't look that far into the future, but I wouldn't be surprised if for certain forms of diabetes, particularly type 1, whether we are able to find a complete cure, if we are able to get alternative sources of beta cells through stem cell engineering or other routes, if we are able to inject that once in a year and then replenish it whenever needed, maybe some forms of diabetes may be totally cured.
You have 1 minute, please.
Okay, I'm done. And therefore, I'd like to conclude that in the last 3 decades, without realizing it, we have made giant strides in the management of diabetes, and the future will only get better. Let's defeat diabetes is a slogan which we have developed. We can and we will. And which better day to state this than on Republic Day? Jai Hind.